So osteoarthritis, those are all examples of osteoarthritis. It's the commonest, common things are common, you'll see it all the time, but understand why it's osteoarthritis. So the hallmark of osteoarthritis is loss of joint space, so that means you've lost your cartilage. So you see that on an x-ray, joint space narrowing. You can't see the cartilage on an x-ray unless it's calcified, but then you're not really seeing the cartilage. So you infer it from the joint space narrowing. You have to have osteophytes to call it osteoarthritis. If you haven't got osteophytes, it's probably not osteoarthritis. It's probably something else. Subchondral sclerosis is another hallmark feature of osteoarthritis. So you can get synovitis with osteoarthritis, but it's not the dominant feature. So that's why you have normal bone mineral density. You don't have juxtaarticular osteopenia. You can get these subchondral cysts or geodes, but the main thing to think about is osteophytes and joint space narrowing. So we'll look at some of the others. So once you see more examples of other conditions, you may be able to try and differentiate. So before we move on, look at these joints and tell me what this is. Oh wait, I've heard people muttering. Yeah, common things are common, this is osteoarthritis. But let's look at it from the terms of learning about the arthritis. Why is it osteoarthritis? So there's loss of joint space in the medial tibiofemoral compartment. There are osteophytes, probably subchondral sclerosis. Maybe we've got a geode here in the tibial spine. So this is osteoarthritis. But the take-home message from today is don't call it osteoarthritis if you're not sure. This is OA, common things are common. Same in the hip. This is osteoarthritis. So we've got a loss of joint space. So you can see here that the femoral head's abutting the acetabulum. So from that you imply that there's no cartilage left there. So you've got a loss of joint space, you've got osteophytes and subchondral sclerosis. So this again we can confidently say is osteoarthritis. This is slightly more difficult, isn't it? Because when we look at this, you could wonder, what's this? Is this an erosion? Is it rheumatoid arthritis in the knee? But we've got osteophytes, we've got loss of joint space. Again, this is probably an example of osteoarthritis. Any takers for this?
Narrowing of the DIP joints.
Yeah, DIPJs, yeah. And probably some small osteophytes. So again, this is osteoarthritis. Same again. Okay, this is getting boring now. Psoriatic. So we'll move on to look at the different ones. So psoriatic arthritis is a bone-producing arthritis. As we said before, the distribution, it can look similar to osteoarthritis. So this is one that you can get confused about. We'll look at those examples in a bit more detail to try and differentiate between osteoarthritis and psoriatic. It's typically distal. It's an inflammatory arthritis, so it's not caused by wear and tear. The primary pathology is caused by inflammation in the synovium. You get loss of joint space, you get bone production, and that's the thing that helps you differentiate between osteoarthritis and psoriatic arthritis. It can be difficult. Sometimes you just can't tell, and that's when you look at the other joints and look at the clinical history. So if we look at some of these other examples, so those previous examples were osteoarthritis. Now we're looking at psoriatic arthritis. So it can look at first glance similar to osteoarthritis, but it's actually very different. So we'll look at it critically. So A, alignment. We'll go back to A, B, C, D. Alignment, are the joints normally aligned? Well, this joint is sublux, so the alignment is abnormal. B, for bone mineral density, is there any juxtaarticular osteopenia? Can you see that? It's difficult, isn't it? You can see this is a scanned in film because we don't have examples of this much joint destruction now because they should be treated. But it's probably normal. So cartilage, we're looking at erosions. Can we see any erosions here? Well, I can see lots of erosions. So if you look at these, look at the base of this third proximal phalanx. Can you see? You probably can't really see that well, can you? You can see there's a small erosion here. Look at the metacarpal head. So erosions can be difficult to see on plain film. You'll see them as a missing part of the bone if you see them on FAS. But look at the head of this metacarpal. You'll see them as kind of radiolucent circles if you're seeing them on FAS rather than tangential. But if you look at all the other joints, there are erosions everywhere. Look at the contour of the metacarpal head. Look at all of the metacarpals. They're all abnormal. But the really distinguishing feature in this, so you know that they're erosions. This has to be an inflammatory arthritis. Look at the other joints, look at the distal joints. Any comments on the other joints?
Fusion.
Yeah, they're fused or they're ankylosed. So this is a productive arthritis. So it could be psoriatic, or it could be a seronegative arthritis. So it could be a peripheral manifestation of ankylosing spondylitis. You'd need the clinical history to try and distinguish which it is. But can you see how this is very different from the osteoarthritis images that I've shown you? So here's another example that at first glance you could say this is osteoarthritis, but actually when you critically analyse it, you can begin to see that it's probably not. So if we go back to A, B, C, D, A, alignment, the distal interphalangeal joints are slightly sublux, but there are no major dislocations. B, bone mineral density, I think it's normal, so it's not that helpful. C, cartilage or erosions, so I can see erosions here. Look at the base of this middle phalanx, you can see there are punched out bits in the contour, so we've got erosions. Have a look at some of the other joints as well. The contour of this fifth metacarpal head is abnormal, so it's probably eroded. And then when you look at the carpus, you start to see erosions on fascia in the carpus. So there are erosions, but the clincher for this is the ankylosis. So these joints are ankylosed. You can't see the joint space at all here. You can't see the joint space here, so these joints are ankylosed. So this is an inflammatory arthritis, it's productive. This is most likely to be psoriatic or one of the seronegative Arthropathies. So you start to see the same thing again, and this is another example of psoriatic. So we'll not labour the point going A, B, C, D, but the features on this, look at this joint here, this is very destroyed. This is not osteoarthritis. Look at these other joints, these are all destroyed. Look at the metacarpals. So this metacarpal is probably normal, the fifth is normal, but the second is definitely not normal. You can't see the normal contour. Look at this joint as well, erosions, erosions, erosion. So if you only looked at the distal joints, you may think osteoarthritis, but look at all the rest. So this tells you it's an erosive inflammatory arthritis. This is starting to look like that description you see in the books, pencil and cup deformity. It just means severe erosions where the top of the joints are eroded away. So this is a nicer example of pencil and cup. I don't really like descriptive terms like that. Just look at the image and try and decide what you're seeing. But you can see essentially the joint is eroded away. This is supposed to be the pencil. This is supposed to be the cup. I wouldn't bother learning terms like that. Just learn that you've seen erosions, the joints are destroyed. It's an inflammatory arthritis. You can see here, these joints are fused or ankylosed, so we're probably talking about psoriatic arthritis or one of the other seronegative Arthropathies. This is a really bad example. So patients, we don't see patients like this anymore. So this patient, this is terrible. This is why these are scanned in films. Because the whole aim of rheumatology today is to try and identify and treat the patients before they get to this stage. So you probably see patients in their 60s upwards with joints like this, but someone who's diagnosed in their 20s, 30s shouldn't end up with joints that look like this. This is terrible. So more examples. So we'll look at this one. Again, at first glance, you might call it normal, but then if you actually analyse the image and look at all the joints, you can see that it's definitely not normal. So first thing, fifth metatarsal head is not normal, there's an erosion here. You can see that the midfoot's not normal here. Here's the intermediate cuneiform, that's also not normal. You can't see the joint space, you can see the second. So is it projectional? Is that why you can't see it? But I think the reason you can't see it is because it's not there, because it's fused or ankylosed. And then look at this first interphalangeal joint, that's ankylosed. Then look at these other joints as well. So this is another example of the same thing, a proliferative inflammatory arthritis. More of the same. So if we look at this film, if we go back to ABCD, this is a nice one to look at the joint destruction. So the alignment is abnormal on this image. You can see that there are subluxations at the third metatarsophalangeal joint, and look at these interphalangeal joints. So the alignment is abnormal. Bone mineral density, not such a great thing, is it? It's probably normal. Cartilage, are there any erosions? Well, we're beginning to see it looks very similar to those other cases that I've shown you. There are erosions. Look at these joints, these are eroded. All of these joints that are sublux are eroded. And then once it goes beyond erosions, then the joint ankyloses or fuses. So here we've got joints that are fused as well. So again, we've seen lots of cases of this now. This is productive inflammatory arthritis.